I'm Dr. John Kruse, and today I'm going to be talking about monoamine oxidase inhibitors and ADHD. So as usual, I'll start with the take-home message, and the take-home message is that MAOI, monoamine oxidase inhibitors, are effective and they're actually our oldest antidepressants. They boost catecholamines such as norepinephrine and dopamine, and indolamines such as serotonin. It's reasonable that they would be helpful for ADHD, particularly because of their norepinephrine and dopamine boosting ability. There is a very limited set of data indicating that at least Deprenyl, one MAO inhibitor, can help with ADHD. Monoamine oxidase inhibitors have not been widely used in depression for 50 years, largely because of dangerous food interactions. Dangers or warnings still exist to some extent when using them for ADHD. So there are subsets of monoamines called catecholamines, such as norepinephrine and dopamine, indolamines, such as serotonin. These are based on their structure. In the body, enzyme monoamine oxidase breaks down these neurotransmitters and essentially neutralizes them. So the process of breakdown is what we call catabolism. Often we use the word metabolize. So metabolism involves both breaking down and building up. So metabolism has two parts. Anabolism, which is building up molecules like anabolic steroids build up your body, and catabolism, which is breaking down. Again, often we just use metabolism when we're mostly talking about catabolism, breaking down of chemicals. In the synaptic cleft, the first neuron releases neurotransmitter, it diffuses across the synapse, it binds to the second receiving neuron at the receptor level. It diffuses up back and forth, on and off. It gets degraded, usually taken back up into the cell and degraded in either of the two cells by enzymes such as monoamine oxidase. Monoamine oxidase inhibitors, again, don't boost the level in terms of making more of the neurotransmitter. They just allow the neurotransmitter to last longer so that it can give a signal for a longer period of time. So effectively, it's boosting the signal or allowing a stronger signal by allowing the neurotransmitter to last longer. Now, there are two main different types of monoamine oxidase, and their differences are based on what they have a chemical affinity for, which they bind more strongly and degrade more readily. And they also have somewhat different localizations. They're found this enzyme within the body, but also within the brain. So monoamine A, its favorite targets are breaking down dopamine, serotonin, norepinephrine, tyramine. We'll get to tyramine in a minute. And its highest concentration in the brain is near the norepinephrine cell bodies and locus ceruleus. It is also the predominant form of monoamine oxidase in the liver and the gastrointestinal system. In contrast, monoamine type B is highest in areas of serotonin neurons in the brain, but its actual target is primarily dopamine and phenylethylamine, which I'm not going to talk about much more. So in addition to these two types of monoamine, some drugs that are specific for A or B, we have most of the older monoamine oxidase inhibitors attack both of these enzymes and inactivated them. So those were nonspecific MAOI. And there's also a difference between whether they bound the monoamine oxidase and just completely destroyed it for the lifetime of that molecule, or were reversible blockers in terms of inhibited monoamine oxidase, but then could diffuse away and allow an intact monoamine oxidase molecule to continue working. Why that's important is, again, most of the older MAOIs were irreversible, and that meant that after taking them, even just for a few days, you've destroyed all the viable monoamine oxidase, and it takes the body about 2 weeks to make a sizable amount of new viable working monoamine oxidase. So for a whole 2 weeks after you've stopped taking the monoamine oxidase inhibitor, you are in a monoamine oxidase depleted state. So again, 2 weeks isn't a magic switch. It's just that it takes time to build up new proteins and about 2 weeks to make a sizable, to recover the amount of active monoamine oxidase. Monoamine oxidase inhibitors were actually the very first antidepressants discovered. And they were discovered because they were anti-tuberculosis agents. Huh? That sounds weird. Iproniazide and isoniazide were being used to treat patients with tuberculosis. They were effective. And a group of really depressed, terminally ill with tuberculosis patients were given these drugs. And doctors noticed it wasn't subtle that these patients who had been depressed were markedly feeling better, were laughing and joking, even though they were on death's door from the tuberculosis. Several scientists, but particularly Nate Klein in the 1950s, observed this and came up with theories that our mental illnesses, particularly depression and schizophrenia were the two big ones they focused on, were due to deficits in monoamines, deficits in chemicals like norepinephrine or serotonin or dopamine, and that supplying them may restore some balance or restore some function. Again, that's a theory that to this day has never been substantiated. It was a logical conclusion based on what they knew at the time, and clearly drugs that boost these chemicals have been found to be consistent in helping with depression and helping with schizophrenia and other conditions, including ADHD. The reason for focusing so much of the last 50, 60 years on dopamine, norepinephrine, and serotonin is that we had drugs that could manipulate levels of these neurochemicals. Each of these is a tiny, tiny system. Norepinephrine, dopamine, serotonin, each is less than 1% of the neurons in the brain use that as their major neurochemical. But these are tiny systems that start out in the brainstem and modulate dozens and dozens of other circuitry throughout the brain. So they're very important in their effects, even if they're small in size. And actually, those being small in size and discrete in area made them easier to study than molecules like glutamate or acetylcholine, which are just so present and abundant that their very abundance makes them harder to study. So I do have videos on glutamate and acetylcholine. For years, the antidepressants we had for treating depression, monoamine oxidase inhibitors, were irreversible and non-selective. So those included isocarboxazid, which is Marplan, phenelzine, which is Nardil, tranylcypromine, which is Parnate. Again, they're all effective antidepressants. Since the early 1960s, when we started getting first the tricyclic antidepressants and then the serotonin reuptake inhibitors, a couple decades later, those two other classes of antidepressants completely swamped the market. So MAO inhibitors for the last 50 years have never been cumulatively more than 1% of the antidepressant market. And it's not in general because they were less effective or that the new drugs were more effective. It's because there was one food interaction with MAO inhibitors that could lead and did lead to killing some people. And that's called the tyramine hypertensive crises. So tyramine is a monoamine. It's not commonly used as a neurotransmitter or something that human bodies are usually producing. If it gets into the body, usually is degraded quickly by monoamine oxidase and inactivated. But if levels of tyramine in the body reach high levels, it essentially causes huge increases in blood pressure, mostly by interacting with norepinephrine systems. So it's not even a direct effect. Really high isn't just mild 140 over 90. This is to levels of 180, 190, 200, 220, where people have a crushing headache and can have strokes and die from it. And again, people have died from it. So tyramine isn't just something that's evenly distributed throughout our food chain. It's present primarily in fermented and aged foods, so particularly certain old cheeses, particularly blue cheeses, certain sausages, red wines, many beers, soy sauces, Marmite, which is bigger in other parts of the world than it is in the U.S., kimchi, sauerkraut, but even overripe bananas and avocados. And one of the problems is that because people have died from this, doctors were so on the alert and worried about what's going to happen. So anytime anyone had something that even looked like a hypertensive crisis when they were on a monoamine oxidase inhibitor, the doctor would write it up or report it to the CDC, and it would get included in lists of foods that were dangerous and high in tyramine. And in those days, the early days of this, we didn't have assays that were easily and readily done that could measure tyramine. So it turned out there were lots of foods, such as raspberries and soft cheeses, that were put on these lists of foods you absolutely needed to avoid, that almost never had high tyramine levels and were mistakenly included on the list. And then there's another change that's happened over the years, and it's essentially tyrosine being converted into tyramine as part of the fermenting aging process. For some of these foods, tyramine is an essential component of the process. But for many of these others, it's actually a contaminant, and due to bacterial degradation, despite it bringing other problems to our food industry, big agricultural, big industrial food processing has decreased all sorts of contamination, reduced food poisonings and other problems. Again, the tyramine isn't intrinsic to the flavor, the development of the food themselves. For some it is, but there are many fewer foods that actually turn out to be dangerous for people who are taking a monoamine oxidase inhibitor. The likelihood of a tyramine crisis does depend on the amount of tyramine that someone consumes. So even if it's rich in a food, if you take only a tiny bit, you're at lower risk. There does seem to be a fair amount of individual variation and propensity to this. And even within an individual, the same amount of tyramine at different times and have different reactions. So we don't know all of the factors that lead to the complexity, but it is not often in psychiatry that we have medications or medication interactions that can cause sudden death, but this is one of them, and this is why monoamine oxidase inhibitors have only been used sparingly. The less they're used, the less familiar doctors are with them, and the less likely to use them again. An additional risk factor with monoamine oxidase inhibitors, and this is less a food medicine interaction, it's a drug-drug interaction, or sometimes drugs alone, particularly the monoamine A inhibitors, which are boosting serotonin level, again, not boosting levels, allowing serotonin to persist for a longer period of time. Serotonin syndrome can be a possibility, and this is particularly when using a drug that is otherwise boosting serotonin levels or allowing serotonin to persist longer for other reasons. So serotonin reuptake inhibitors, pain medications like tramadol that boost serotonin levels. There are certain digestive system like omeprazole that are boosting serotonin, dextromethorphan, ingredient in cough syrup, but also in Auvelity, the new antidepressant. So there's a number of different drugs that can boost serotonin, and in conjunction with taking a monoamine oxidase inhibitor, make it even more likely that someone's serotonin level rises too high. And does that mean everyone who takes an MAOI and one of these other drugs is doomed? No. This is a dose-responsive effect. It's one that varies in terms of sensitivity, person to person, and again, other additional factors. Consideration, again, is that particularly with the original irreversible MAO inhibitors, you had to wait at least 2 weeks after stopping one of those before you could start someone on Prozac. Because again, the residual effect would be that you have still inactivated MAO, and then you're exposing them to higher serotonin through another cause. In general, aside from these two highly dangerous and moderately uncommon or due to specific interaction problems, MAO inhibitors tended to be generally well tolerated. Some people have nausea, some people have dry mouth. They could cause dizziness, mostly through causing low blood pressure rather than high, or orthostatic hypotension. Weight gain is moderately common with them, and sleep disturbances and sexual side effects, as some people have on SSRIs, are also present, but generally they're pretty well tolerated. But to help particularly avoid some of these really dangerous reactions, we've developed different types of monoamine oxidase inhibitors in recent years. Drugs that are sensitive, particularly for the monoamine B form, so that's boosting primarily dopamine, also phenylethylamine, but having much less effect on serotonin or tyramine, so they're generally safe to use with other drugs and with any foods. So we have one monoamine B inhibitor, which is selegiline or Deprenyl. There's also several that are used specifically for Parkinson's to boost dopamine levels. So rasagiline, which is Azalex, sulfonamide, which is Zydago, and others. There is a reversible monoamine A inhibitor called moclobemide, which is used for depression. It's never been approved in the US. Specifically, there's an interesting form of Deprenyl or selegiline. Again, selegiline's a type B, so it already has a low risk, available as a patch form called MSAM in the US. So MSAM helps avoid what's called the first pass effect. Drugs that are digested, the blood supply from your digestive system goes straight to the liver through the portal vein, and the liver is a chemical factory which breaks down and modifies lots of chemicals. So drugs that are digested, many can be inactivated by all these liver enzymes, whereas if the drug is directly added to the bloodstream, eventually some proportion is passing through the liver, but much more of the drug is available to circulate and then therefore get into the brain. So an important thing is, again, there's a lot of monoamine oxidase in the liver. By delivering the selegiline as a patch, it's interfering less with the inactivating the MAOI in the liver, which means if someone still takes some tyramine while taking selegiline patch, they're less likely to run into a tyramine crisis, even though, again, it's a type B, so there's less of that risk to begin with. Really important thing with selegiline is, separate from its MAO inhibiting properties, is what happens to selegiline itself when it's broken down. And it's broken down into primarily L-methamphetaime and L-amphetamine, both of which themselves could be active agents for treating ADHD. Whether also boosting serotonin adds anything for ADHD or not. Again, so a triple reuptake, not reuptake inhibitor, but a triple booster. So maybe like centanafidine, which is under development for ADHD as a triple reuptake inhibitor, actually has weird implications for selegiline. So yes, less of the liver MAO is being inactivated, so you're safer in terms of tyramine, and you're also therefore having more selegiline around that can get into the brain, that can therefore influence brain levels of dopamine, norepinephrine, and serotonin. But also, because of your avoiding the first pass effect, you are breaking less of it immediately down into amphetamine and methamphetamine. So it's not clear whether the patch form selegiline and SAM patches, by avoiding that first pass effect, is becoming less effective for ADHD or more. I could only find 4 studies, 3 of them which are at least 20 years old, looking at selegiline Deprenyl for ADHD. The biggest of these studies only had 28 subjects, so this is a total of less than 100 subjects. Most of them were kids. One study was in adults. And they did indicate that selegiline could have benefit for ADHD symptoms, that it was comparable to other non-stimulants. Amount of data available is pretty minimal. So a few other things about monoamine oxidase inhibitors. For years and in many textbooks, and this may be true, it was touted as being particularly good for atypical depression. Depressions that are characterized by sort of slowish, sluggish signs, so someone's sleeping a lot rather than having insomnia. Someone's gaining weight, someone's less, so rather than being anxious and irritated, they're slow and sluggish. They also tend to have mood reactivity, so rather than just being flat, they get upset readily, or if something good happens, they can be briefly happy for a short time, but quickly regress to a depressed state. And rejection sensitivity. Now, there's some studies that indicated that MAOs were better for atypical depression than tricyclics or SSRIs, but there's at least an equal number of studies that didn't find a differential effect. Part of this is the chronic problem in psychiatry of really poor measures of measuring efficacy. So I'm not saying that we don't know that MAOs are more effective for atypical depression. I just think the claims are overstated because there's at least as many studies showing they couldn't show a preferential differential effect for MAO. Also sort of wrapped up in this became a myth in the 60s, 70s that MAOs were good for atypical depression, but they weren't as good for standard melancholic depression where someone's prevailingly sad and usually has insomnia and weight loss. Interest in it for atypical depression, where rejection sensitivity is part of it, led in part to some clinicians promoting MAOIs for specifically treating rejection-sensitive dysphoria. I have a whole talk on rejection-sensitive dysphoria. I don't think it's something that's specific to ADHD, and I don't think everyone with ADHD has it. No published research showing that MAOIs are more effective or less effective than other antidepressants for treating rejection-sensitive dysphoria in the context of ADHD. Methylene Blue, I have a separate talk on that, is an industrial dye used for textiles and paper. It does have reversible monoamine type A, which means it should boost serotonin, dopamine, and norepinephrine. At very low doses, it's probably safe. At higher doses, it should and has been found in some cases to cause a tyramine effect and also can cause serotonin syndrome. People touting methylene blue for ADHD, again, not a single study as of June 2025 that I can find. It's plausible that it might work. Dosing is a concern because methylene blue has other properties, particularly with electron transport. So I would say it's not something to dabble with lightly, but it may well have benefit for ADHD, just not clearly demonstrated. And one other concern is the interaction between stimulant medications and monoamine oxidase inhibitors, and particularly because amphetamine, not Ritalin, methylphenidate, doesn't do much of this, but at high doses of amphetamine, there can be considerable serotonin reuptake blockade. So there are some concerns about causing serotonin syndrome when using a monoamine oxidase inhibitor with high-dose amphetamine, so that should be generally avoided. And in particular or overall, if you're on any other psychoactive medications, monoamine oxidase inhibitors should be started at a low dose and cautiously observed. So that is all I have to say about monoamine oxidase inhibitors and ADHD. Stay healthy and happy.